Get started.
Okay. Hi, everybody. I'm Rachel Rabinovitch. I'm a professor of radiation oncology at the university. And Marie kindly asked me to speak to you today about that black box experience in cancer therapy of radiation oncology. And so I wanted to give you just sort of a broad overview, and feel free to ask questions, or I'll try to finish up a bit early so you can ask questions at the very end. I tend to be a fast talker, so Marie, if I start speaking too quickly, just slow me down. So radiation therapy has really a very long history, going back to the 1800s, and I'd just like to give you a little bit of background and then explain what I'll call the care path, or the road map that patients go through from the time of a consult to finishing treatment, and what that looks like and some of the treatment approaches that we use today. The first thing to share is that radiation therapy, perhaps more than other fields, or maybe similarly, is really a team sport. It's not just a physician. It involves numerous people, including medical assistants and nurses. That probably is not surprising. But there are people who are trained to do very specific components of the setup, planning, and treatment process, such as people who are involved in the treatment planning process. We call them simulation technicians or therapists, dosimetrists. There's a special certificate certified medical dosimetrists who understand how to design radiation plans and understand the physics and the aspects of radiation treatment techniques. Master's or PhD level physicists, radiation therapists, and patients frequently say to me, like, "You're going to treat me though, right?" And I say, "No, you really don't want me doing that. I don't know how to operate those linear accelerators," in the same way that medical oncologists don't deliver the chemotherapy. They prescribe the chemotherapy regimens, and they rely on nurses and pharmacists to deliver the drugs. And if you stuck, one of the medical oncologists in a pharmacy and say, "Go," they would have no idea what to do. So it's very similar for us. Then there's us, the physicians. There's all of you, the wonderful research staff, from data collectors and people who speak with our patients and consent them, enter the data. I don't need to explain that whole aspect to you. And then lots of support staff throughout our department. How do we get to be radiation oncologists? It might be a little surprising. We do a year of a general internship. Usually that's medicine, but it can be surgery or pathology. And then it's a 4-year residency program specific to radiation oncology. And some of the fun little pieces of what we do is that we're really the only specialty in all of medicine that are very specifically and expertly trained to examine every part of the body. So we are equally comfortable doing a laryngoscopy and evaluating the vocal cords and using an endoscope to do that, as we are doing a pelvic exam and understanding the anatomy of the cervix, the parametria, et cetera. So you can't really say that about any other specialty. We spend more time learning cancer than medical oncologists do. They spend 3 to 4 years in medicine, I think it's 4 now, and then 3 years in oncology. So we actually spend more time learning cancer than medical oncologists, but part of the drawback is we're not internists. We don't know how to manage sepsis and give platelets and transfusions and pneumonias and deal with inpatient management. So that is our limitation. There aren't too many fellowships for us. There are a few in specialty procedures, but as a general rule, we don't subspecialize through fellowships. And we have a deep understanding of radiation biology and radiation physics. We take written boards and then an oral boards, which is still for some historical reason in Louisville, Kentucky. And this is sort of the stereotype of a radiation oncology nerd.
Who smokes?
Pardon?
Who smokes? Wasn't that a sick?
Yeah, that was pretty funny.
Oh.
So early obstacles in radiation therapy was that the early radiation therapy treatment energies were very low. And what that means is that it deposited the majority of the energy in the skin, and the energy steadily fell down as it penetrated the body. And what that meant is that skin toxicity was really the primary obstacle, but that's no longer an issue for us because we have high energy X-ray beams. So I'll point you over. Can you see my mouse moving over here on the right? Maybe. What we have today are high energy X-ray beams, which deposit their energy deep inside the skin surface and really minimize skin toxicity, which used to be a primary problem when delivering radiation treatment. The radiation energies that we use are in the 4 to 16 megavoltage range, 10 to 10,000 kilovoltage. And for diagnostic X-rays, you can see that they are several logs lower as far as energy. Oops. This is old, but it hasn't changed tremendously. This is a picture of an early cyclotron in Berkeley. A lot of radiation oncology started in California, Henry Kaplan at Stanford. And essentially, once a machine was designed that could create a radiation beam, and that's essentially what a linear accelerator does, we can then modify it, control it, and deliver that radiation beam through multiple angles. Can you see my arrow, Marie? Can you just tell me if you see my arrow?
Yes, we can see it.
Okay, so this is called a gantry head, and this rotates 360 degrees. And so it allows us to deliver radiation beams in a 360 degree arc around a patient. The patient lays on what we affectionately call a couch. And this couch can also rotate, the feet swivel left and right. And so that essentially creates a limitless number of beam angles. Just to show you the difference between when you go for an X-ray of your spine using a low energy beam in the radiology department, this is what you see. And the low radiation energies don't penetrate the dense bone tissue. Hence, you get this picture which discriminates between soft tissue and dense bone tissue. And that is what is useful about low energy beams for diagnostic imaging. We don't want that for radiation treatment because we want to penetrate evenly through all this tissue. There is a little bit of a differential, but that same field or that same beam using the kinds of energy beams that we use, you can see that it's much more difficult to see the bony anatomy. And that's because our high energy beams penetrate almost perfectly evenly through all that tissue. So then the question is, okay, you can deliver this radiation beam at tumor or at tissue. Why does that do anything useful? And so what radiation does is it creates electrons that are released, which hence interacts with oxygen and water to create something called a free radical. And these radicals are free radicals are really the bullets of radiation oncology. They create double-strand DNA breaks in the DNA of what it passes through. And so here you can see sort of the photon, the radiation beam coming in, the electron interacting with water, creating a free radical that then is the bullet that damages the DNA as it flies through a cell. And that damage causes a whole host of different types of cell death. We used to think that cells just died in one way, but there are many ways that that can happen. And sometimes that's immediate. Sometimes it can take days to weeks to months. And even after the cell has died, it takes the body time to haul the garbage away. And so that's why at the end of radiation treatment, we don't always do a scan immediately. You want to give time to see a radiographic response. Even if you have dead tissue, it may not be apparent on a CT scan or on a PET CT scan. And so the other thing, I don't have a slide that points this out, but the other reason it works is because normal healthy cells have very sophisticated DNA repair mechanisms that repair the DNA damage that we caused over here. Whereas by a miracle of science and God, tumor cells do not have that ability. So we direct the radiation beam at an area of the body most likely to have cancer cells. We try to eliminate as much normal tissue as possible. but whatever normal tissue is impacted has the ability to repair itself from the radiation, which cancer cells cannot. This is sort of a schema of the general care path, and we'll focus on some of this one by one. A patient has to see us in consult. Unlike many other specialties, like surgery, perhaps, we are a secondary referral oncology specialty. So usually a patient is diagnosed with cancer only after a biopsy or seeing a surgeon or having a surgical intervention. And then someone has to refer the patient to us. We always perform a history and physical. We always review all imaging studies, pathology, confirm the staging, because that is really the foundation of what determines what treatment modalities are either options or optional for a designated stage of cancer, offering the patient either options that include radiotherapy or recommending radiation as a necessary standard component of treatment. And then we always have the patient sign an informed consent. Hang on one second. Hey, can you just open the microwave? It's beeping. Thank you. I'm good. And just interestingly, I think it wasn't until a few years ago that medical oncologists had to have patients sign consent for chemotherapy, which is fascinating to me. But radiation oncologists have always done that. The next process is simulation, which is setting up the patient in the treatment position and acquiring the anatomical information to plan radiation. After that, the radiation oncologist will identify, and I'll show you examples of all these pieces. Then the planning process is performed. There's a quality assurance piece. The treatment is actually delivered. So between the consult, after the simulation, this piece happens without the patient needing to be in our department. And then the patient comes back for treatment, and then there's post-treatment follow-up. I think this is just another way of saying what I've already said. Okay, so simulation is a word you've probably heard. And what it does is it simulates the treatment position. Today, all treatments are based on CT scans where the anatomical data for the treatment area and the surrounding normal anatomy is acquired. And today, that data from a CT scan performed in the radiation oncology department is integrated with radiation therapy planning software, which allows reconstruction of the patient's anatomy and disease in 3 dimensions. So essentially, we do the CT scan, let the patient go home, but I essentially still have their body with me so that I can plan the radiation for them. And during that process, we immobilize them. We want what happens at that CT scan to be reproducible every day that they come back for treatment. And that means that we need to be able to position them in a way that they won't be able to move during treatment, between treatments, and when they come back for each treatment, it's reproducible. So that process, which uses molds or masks, and I'll show you some examples of those, is called immobilization. We scan the area that we're going to be treating. If we're going to be treating a brain tumor, we don't need to scan the pelvis. If we're treating the chest, we don't need to scan the brain. We usually use 3 millimeter slices so that we get very fine data collection. Sometimes we go even thinner. We might use various types of contrast, oral or IV contrast, and we'll talk a little bit about managing the movement associated with just breathing. We have ways of controlling for that when we want to treat, let's say, a small tumor in the chest, and we don't want to be concerned that the tumor, the lung cancer, is moving up or down. This, I think, just summarizes what I said. We put the patient in the treatment position, and that's a thought out process. Do we want the arms down or up? Do we want the chin extended or positioned down? If we're treating the pelvis, do we want the knees in a frog leg position? How do we manage all that? And so this is what a CT simulator looks like. It's essentially a CT scan. It uses a flat board because our treatment machines have a flat couch. So unlike diagnostic scans, which have a rounded couch surface, ours have a flat surface. And other than that, is essentially a pretty standard CT scan. When I was training, we used to use fluoroscopy, but that was essentially because CT scans were not yet integrated into the radiation treatment process. Ultrasounds are used on occasion, and MRI is a growing area of both treatment planning and as well as treatment delivery. The other thing to point out, this is just another angle of the CT scanner, is, so here's an example of a breast cancer patient. We've used a special device designed specifically for women getting breast radiotherapy. This is a standard immobilization device. Their arms are up over their head. There are certain positions for those arm holders. The angle that the chest is elevated is specified. We want them to be comfortable. There's a wedge under their knees, and this will be exactly the same every day during treatment. Depending upon what we're treating, we might want to outline some surface anatomy. So a lung cancer is easy to see inside. For breast specifically, which is a very common area of cancer treatment, there's actually no neat anatomical boundary on CT for the boundaries of breast tissue. So we use a combination of CT data and clinical palpation of breast tissue. And so this wire is visible on a CT scan. We outline the lumpectomy incision that's not visible on a CT image, and where the nipple is, that's surprisingly not always easy to see. And then there are the famous tattoo dots, which are used less and less, but when we use them, what they are is not necessarily to direct exactly where the treatment is being delivered to, but it's to position, it's to enhance the precision of the patient positioning on a daily basis. And so once the patient is scanned on the planning process day, there are laser lights on the sides and on the top of the patient in the CT planning room that are in the same geometry in the treatment room. So once a patient lays down, that probably gets us 80% of the way to where we want to go, but we may need to make subtle adjustments to the patient position so that those little tattoos will line up on the crosshairs every day during treatment. Other things that we do before we scan is we might give people oral contrast or IV contrast to outline where the blood vessels are, contrast in the rectum, or place little markers in the anus. Further immobilization devices might be masks. This is for a patient who's going to undergo stereotactic radiotherapy. If treating a patient to the head and neck, we might want to move the tongue away from, let's say, the hard palate in the nose to avoid dose to that structure. If we don't need to treat the tongue, we don't want the patient to experience toxicity. If we want the head and the shoulders in a specific position, we have these masks, which again can be molded to conform to any person. And then we scan the patient, and then comes the process called contouring, which the physicians do. And that identifies what we do want to treat and what we don't want to treat. Hang on one second. Okay. Sorry about that. And so here's an example of a woman with breast cancer. Actually, that's not an example, but if I'm treating a woman for breast cancer, I want to identify the breast that I do want to treat, what I don't want to treat. And this example is a woman who has, let's say, a tumor in the chest that's causing shortness of breath. It's a metastatic lesion. She gets scanned, and this mass in the center of the chest is the cancer, is the tumor. These white circles are the normal blood vessels that are brighter due to having contrast in them. And this is her airway, her trachea, which should be over here in the middle, but is being pushed over to her right due to the cancer. And so we would identify what we call a gross tumor volume, what we want to treat. We would identify what we don't want to treat, and based on that, we can design the treatment fields. The CTV is a term that reflects what we call the clinical target volume, and that is allowing for microscopic disease to extend beyond the boundaries of an obvious CT tumor. And then the planning target volume, or the PTV, is the purple, which allows for a little bit more room of expecting a very small amount of position variation from day to day. We identify what we call the organs at risk, or the normal tissues that we don't want to treat, the left lung, the right lung, let's say her chest wall that might have previously been treated. And this again is just a summary of what the contouring process involves: the gross tumor volume, microscopic extension beyond what is obvious, and a little bit of extra room for uncertainty. This is just demonstrating all that. Once the physician has outlined all those normal and target structures, we have to provide the team that helps us plan the radiation by saying, what dose do we want to use? The physician and or the dosimetrist will determine what beam energy we want to use. Usually the more superficial the structure we want to treat, the lower the energy. The deeper the structure or the target is, the higher the radiation energy. How many treatments we want to give, or how many fractions we want to use. Is it a daily treatment regimen for 6 weeks? Is it a single fraction or 5 fractions delivered every other day? That's all part of the fractionation schedule. Imaging today before a treatment is very common when we use very sophisticated, precise treatments that depend on very accurate patient positioning. And then sometimes we apply certain devices on the body in order to achieve the treatment plan that we want to use. Once the dosimetrist has provided us with a treatment plan, the physician evaluates it by reviewing what we call a dose volume histogram, which reflects where dose goes, how well a structure is treated or avoided, and looking at the tolerances to make sure that we're respecting the doses that normal structures can tolerate. So this is the simplest type of radiation treatment. This is often used for palliative treatments where long-term toxicities are not an issue, or we're not using very high doses. And this is just a simple plan where the beam is coming from the front and from the back. Here we're treating bones, and you can see that these little, we call them leaves, these little white things, they're blocking radiation, and the radiation is only going into the open space here. And this is a plan specifically meant to treat the pelvic bones. So there isn't a need to treat the center of the pelvis where there's only or normal tissues and it's not part of our target. And this is just a very simple treatment approach. These color lines outline where the radiation goes. And so the dose, the prescription dose would be the red, and then there are slightly higher doses in the front and in the back, which are considered acceptable. Then we move on. This is actually not exactly how we do things anymore, but for breast cancer, the approach is what we still do today, where we take advantage of the fact that the breast, which is outlined by my arrow here, is essentially outside of the body, and we want to take advantage of that. So we treat the patient with what we call tangents. They're beams that move tangentially through the body surface, through the chest, so that we're not going through the back of the body and through the heart and the lung in order to treat the breast tissue. Now, we don't do this exactly anymore. Here you can see the great majority of the heart is not getting any radiation dose, but you see that the little tip of the left ventricle in this example is getting some radiation. And I should have updated the slide, I apologize. But what we do now for the last, I'd say 5 to 6 years, is something called deep inspiration breath hold. And that's where before we treat this woman, we would instruct her to take a deep breath and hold it. And what that does is when you expand your lungs with air, this little bit of lung gets bigger and it pushes the heart back away from the breast tissue and down in the chest. And that would completely push the heart tissue out of the radiation field. And so today, the doses that we give to the heart for women with left breast cancer is absolutely negligible. And I'll just say that this deep inspiration breath hold is a very sophisticated automated process where there is a box on the belly of the woman that is detected by a camera that is connected to the treatment machine, so that if in the middle of the deep inspiration breath hold, she got a tickle or a cough and let go of that deep breath, the machine would detect it instantaneously and the beam would be shut off. Here is an example of a prostate cancer patient. This is the target with margin, and you can see how nicely the green prescription dose conforms to the target. The purple is only 50% of the dose, and you can see how that too is very confined around the area. So now we have ways of giving radiation therapy that really minimize meaningful doses to structures around our target. Here's another example of a brain tumor, a GBM or a glioblastoma multiforme, where again, the radiation is very well confined to the area of brain that is being targeted, avoids sensitive structures like sinuses and orbits, eyeballs, and the contralateral portion of the brain gets a negligible dose. Once a treatment plan has been approved, there's a quality assurance process that is taken care of by our amazing physics team, often which is done after hours. They work very late hours because they have to do this quality assurance process of the approved plan on the treatment machine. They run through the plan to make sure it's deliverable, and that has to be done at the end of the day when the patients are no longer being treated. And these are just analyses and dose clouds to verify that what is being delivered is a reflection of the treatment that was designed. So once all that is approved, prescribed, verified, the quality assurance has been signed off, the patient begins his or her treatment. Again, we mentioned that the treatment is delivered by radiation therapists. Most treatment courses are given on a daily basis, Monday through Friday. Treatment courses are dropping precipitously. I don't know that anybody gets 9 weeks of treatment anymore, but I would say the longest treatment courses are 7 weeks, perhaps, for a prostate or maybe a head and neck cancer patient. And there are many curative therapies now that are down to 1 week. In the last 2 years, there are definitive radiation breast cancer treatment approaches that are only 1 week. We might image the patient while they're on the treatment machine on a daily basis, and patients are evaluated by the physician at least once a week to make sure they're not having unacceptable side effects. Sometimes it's to assess the tumor response. Once the treatment is done, we do an end treatment visit, and also make a treatment summary summarizing exactly what is done, what was done. And these are some terms you might hear. 2D is just the simplest type of radiation that I think I showed you at the very beginning, treating that right pelvis. 3D conformal radiation and IMRT are the two mainstays. IGRT is not a type of treatment, but it just demonstrates that we need to do some image guidance in order to deliver the type of treatment. IGRT is usually used with IMRT. And then SRS and SBRT are ways of giving very high doses of radiation to small structures on a daily basis. So typically, I would say a daily radiation treatment course gives somewhere between 1.8 to maybe 3, 4, 5 gray per day. And SRS, SBRT might be giving 10, 15, 20 gray in a single treatment. Again, here's an example of 3D radiation where we have a target and each beam is designed to contour, be conformal around our structure. These beams are all kinds of shapes, and that's because tumors aren't perfect circles or squares, and they're tucked into spaces where there are normal structures that we need to avoid. Intensity modulated radiation therapy is when the leaves, these are these blocking metallic structures, are moving during delivery of the radiation beam, and that provides the radiation oncologist and the dosimetrist with a whole additional layer of ability to define the radiation dose to a very conformal tight space. And just to give you an example, 30 years ago, if you needed to treat the pelvis for, let's say, rectal cancer, you would use 4 beams, front, back, left, and right, and you'd get a very nice even dose to cover our target, which is, I think you can see these little blue outlines, but we also end up treating a lot of normal tissue in the middle. So this worked well as far as curing cancer, but it gave tolerable but significant toxicity in the form of diarrhea, pelvic discomfort, urinary symptoms. And now with IMRT, look how beautifully we can shape the radiation. And many studies have been done demonstrating that that obviously cures the cancer just as well, but dramatically decreases grade 2, grade 3, and other toxicities and improves patient quality of life. And the sophistication with which these beams were done, this was just a sort of, I'm going to do this because I can, but using these beams, this is an X-ray picture of Albert Einstein clearly using a beam and varying its intensity across the field, which just shows you how sophisticated our planning process is. We've talked about taking imaging before. Our linear accelerators, which deliver radiation out of the head of the machine, the gantry this way, these linear accelerators are now designed with onboard imaging. So these side pieces deliver X-rays, which can be catched on a digital processor, so we can see the patient who's laying down right in here before we treat the patient. Again, this is just what our imaging looks like on the treatment machine. It is nothing as good as a diagnostic quality, but often enough that we can align the bones or other organs very well. Move on through this. We also have surface motion now. It's called image guidance, where the surface of a patient can be evaluated once they lay down through these infrared cameras, and we can adjust the patient positioning again before the patient is treated without taking X-rays. This is just to give you a little bit of information about stereotactic radiosurgery. That's the technique. It was initially designed by neurosurgeons and radiation oncologists to treat brain tumors. And stereotactic radiosurgery is the technique that can be delivered by specific machines. So Gamma Knife, there is one in our hospital, not in the radiation oncology department, that gives stereotactic radiosurgery. In the radiation oncology department, we have linear accelerator-based SRS, and there's a type of machine called CyberKnife. This is sort of just like generic types of machines versus generic type of machine. Sorry, did I say that backwards? So these are sort of specific brands, and this is generic, but they do exactly the same thing. And these are very high precision, within a millimeter or 2 accuracy, which allows us to give very high doses. We talked about, typically we give 10 to 22 gray in a single fraction, and it's usually used for brain tumors. We used to use this technique using a frame that was literally screwed into the patient's skull. And now we use frameless radiosurgery, where we have very tight masks that we can make so that we don't need to literally screw into the skull bones, which is obviously nothing anybody needs to do if they don't have to do it. So whole brain radiation is when we treat the entire brain. 3D or IMRT to treat a brain tumor would over here on the right, usually for larger structures, and typically for lesions that are 3 centimeters or less, that's amenable to stereotactic radiosurgery. I think this is repetitive. Again, here's an example of a lung cancer. In the old days, 30, 40 years ago, we would treat patients with 2 simple beams because we didn't have CTs integrated with the planning process. Now we can be extremely conformal in an effort to treat that tumor to the same yellow dose, see how much less tissue is getting that yellow prescription dose, minimizing toxicity and risk. We can be very specific in treating tumors in the spine and avoiding the spinal cord. It allows for decreasing risks to other normal tissues, and high doses per treatment are particularly useful for certain tumors that are what we call radio resistant or need higher doses for the radiation to work well. And two examples of this are melanoma and renal cell carcinoma. There's also implantable types of radiation, brachytherapy. This is an example of multiple catheters used to treat a tumor bed from which a sarcoma was removed. We do brachytherapy regularly for cervix cancer. And maybe I'll just back up before I see if any of you have questions. And we have what we call a high dose rate machine, high dose rate brachytherapy, which would allow this patient or a patient with tandem and ovoids or devices implanted in the uterus and around the cervix, where the catheters are connected to a machine which is controlled by a computer, and a radiation source slips into each catheter consecutively to deliver a finely shaped radiation treatment cloud around the tumor or the volume that needs treatment, or around the cervix. That's the most common way. So that's basically a summary of the very basics of radiation therapy. Sometimes it's easier to come look, and I invite you to come visit me or my colleagues anytime, and I can show you a patient on a real radiation machine. What I should have said, I forgot to say this at the beginning, is that when patients are treated, they feel absolutely nothing. They are never radioactive unless they have a permanently implanted device in them. The treatment itself typically takes 2 to 3 minutes during a 15-minute appointment. That is the same time every day. Patients can drive themselves to and from these appointments. They don't glow in the dark. They don't lose their hair unless radiation is delivered to the head. And even then, if it's an SRS or a finely shaped technique, they may not necessarily have any hair loss. So those are just some of the basics of information that I think every patient wants to hear or needs to hear. So I'm going to stop sharing. You can feel free to reach out to me at any time by phone or by email. And if anybody has any questions, I'd be more than happy to entertain them. And if you'd like to ask me later at another time or by email, you are welcome to do that as well.
Thank you, Rachel. I think, when you talk about kind of the sparing thing, I think I've shared with you before that my husband had Hodgkin's disease and had high dose mantle radiation back in the 1970s. And I think he was, he was 39 when he had his first heart attack. As a result of the radiation therapy. So the ability to be able to really hone in on the tumor and to spare all of the other tissue, I think is a great advance. And if any of y'all haven't seen how they do this mapping and how they do this preparation, it is absolutely fascinating to watch how they plan and how they map this, and then how the actual radiation is delivered. I've seen it a couple of times and it's pretty incredible. So
I'll just expand, Marie, that one of the, thank you, that also triggers me to speak to one other thing, is that much of radiation oncology research has been so dramatically furthered because of our ability to image either through CT scans or dynamic imaging, functional imaging, such as PET scans. So in the old days, we really had to treat very large areas to be sure that we were treating what we thought we need to treat. And today's radiation studies are constantly trying to pare down, taking advantage that we can see what we're treating now, and we can see the impact of chemotherapy when they're combined, to treat less of a patient, to use treatment techniques that treat less of a patient. The deep inspiration breath hold that I mentioned is a way to take the cardiac toxicity that used to be a real issue with breast cancer. We used to cure breast cancer well, but we killed some women from causing long-term cardiovascular disease. So really in the last 20 years, the ways in which we have been able to minimize what we treat, lessen the dose, and design techniques to avoid other structures has really been phenomenal. How I was trained to how I treat now is almost unrecognizable to me. Certainly not recognizable to my residents.
Right. So what do you see for the future?
So I see a combination of things. There are certain areas in which I think radiation is disappearing. I treat breast cancer and lymphoma. In the world of lymphoma, while radiation has a very important role, I would say about a third of the patients I would have treated 20 years ago, we don't need to anymore, which is wonderful. And targeted therapies and better systemic therapies are helping us to either avoid treating patients in all diseases or in treating them, I'm thinking of lymphoma right now, but in treating them to lower doses. In breast cancer, the 1 week approach, which I'm starting to use now, is a far lower dose than we ever used before. So learning how to divide up doses and give them, and that we can give them safely helps them. Someone asked a question on the chat about the abscopal effect. And the abscopal effect is a term which, in its pure sense, describes a phenomenon where if I treat a patient who has melanoma all over the body, but has a painful tumor, let's say in the armpit, and I radiate only the armpit, there have been multiple scenarios where not only does the tumor in the armpit shrink because I've radiated it, but that stimulates an immune response such that the body causes shrinkage of tumors in other parts of the body. Now, that is by far the exception than the rule, but a lot of research has been going on in the area of using immunotherapy or the immune system and using radiation to uniquely disperse tumor antigens to which the body's immune system can be stimulated and interact with tumors. And so radiation can be used now in a whole new way. It's really in its infancy, but that is an area I think where we can go to, where radiation will be used not so much to treat the tumor because we're making that tumor shrink, but because it's a treatment to stimulate the immune system by letting tumor antigens out into the body's access, I guess. And then combining immunotherapy. It's fascinating. It's crazy stuff. This is crazy stuff. And you wouldn't believe it if you didn't do it and you didn't see it. So this is an area we do a fair amount, let's say also in the lymphoma world. Again, that's just where I live. But in patients who have been given CAR T cells and have been given these very specific primed T cells, that sometimes when they seem to stop working, we can give a moderate dose of radiation to a lymphoma area, and that can stimulate the immune system and the patient can have a whole body response. So it's certainly a growing area of research that is really just getting off the ground.
Okay. I have one more question. Is there anything in the chat? No, everything's in the chat's been done. So how is palliative care different from the treatment? Do you use like the same doses, but it's not curative, or what are some of the idiosyncrasies between the two?
Do you mean specifically with the abscopal effect, or just?
No, just palliative, just palliative care in general.
Oh, palliative care. So there are many ways of delivering palliative radiation. I would say as a general rule, when we say palliative, we know, number one, that the treatment we're going to give is not meant to cure the patient. So we'll say a man with metastatic prostate cancer in his bone and in his liver, if he's having pain in his T4, T5 spine, the radiation we're giving isn't meant to extend his life. The radiation is meant either to decrease his pain. Maybe he has cord compression and we want to prevent neurologic compromise. Maybe someone has a tumor in the chest. So we're trying to palliate a specific symptom. Traditionally, we do use lower doses in shorter time span that aren't necessarily meant to prevent the tumor in that area from ever coming back, because we know they have a limited lifespan. So we just want to deliver a treatment that we think is highly likely to control the disease for the remainder of a person's lifespan. Having said that, cancer therapy has changed tremendously. So there are women with metastatic breast cancer whose lifespan isn't 6 months, but there are women with bone-only breast cancer that can be expected to live 10 years or more. And I expect that number to continue to grow. So what palliation means, I think, has also shifted, and that's part of the analysis by the radiation oncologist, is what kind of cancer do they have? What kind of treatments have they had that have worked or have not worked? Is their life expectancy 3 months, 6 months, which might generate, a simpler, lower dose radiation plan that is meant just to control the disease for the rest of their limited time? Or is it a woman who has a metastasis in her spine, but I expect she will live another 10 years? For that, I might deliver an SBRT or a very sophisticated higher dose treatment, because I need that to last for her, that palliation to last for her for many, many years.
Can you radiate a place more than once?
So every part of our training is to understand. So the answer is yes, but part of our training is to understand that every organ in the body has a unique maximum of radiation dose that it can tolerate. That's related to the organ. It's related to the volume of that organ. So I can treat, one area of the liver, which doesn't impact the next area of the liver, but I have to consider how much of the liver has been treated over time. I might be able to retreat an area of the liver if I know there's a certain amount of healthy liver I'm leaving alone. That's a for instance.
So the cumulative effect.
It's a cumulative analysis of both dose, component of an organ, thinking about, a liver is different than a lung, the spinal cord, what the consequence is, can I take out one kidney? I might need to. I know if someone has another healthy functioning kidney, that might not be a problem. And that's part of a discussion with the patient or certain tests. Do you have 2 functioning kidneys? If it's absolutely necessary to radiate a tumor in a kidney that might cause permanent kidney failure on that left side, that might be perfectly not an issue for a patient with a perfectly healthy contralateral kidney. So it's understanding, the whole of what we're doing.
Yeah. Okay, anybody got any questions? Let me check the chat again. There's nothing in the chat. Any questions or comments, guys? Okay, Rachel, thank you so much for coming again.
My pleasure. And again, anyone is welcome to reach out to me at any time.
Okay, great. Thank you. All right, we'll break until 1 o'clock. Grab yourself a bite to eat, and then when